Hello, students. This is Dr. Talaga here, and I thought I would do a little Talaga Talks telemetry. This has been a highly requested video by my students, so I thought I would make one up and put it on here. It is a very simplistic overview of a normal heart rhythm. This is specifically for those early level nursing students. Yes, it does get more complex than this, but this is a great starting point. So when nurses are looking at a telemetry strip, how are they interpreting what the rhythm is? No, we actually don't just match pictures to what it most looks like. There is some critical thinking involved and a very systematic approach to interpreting what the rhythm is. So first part is you really need to understand what normal is and what normal sinus rhythm actually is. As many of you have learned, we do have a normal sinus rhythm kind of drawn out here. So normal sinus rhythm includes a P wave, a QRS complex, and a T wave. All right. So when we're reading our telemetry boxes, you have here that there is 5 small boxes equals 1 big box if we were actually looking at a printed out telemetry strip. So in order for it to be normal sinus rhythm, first of all, we know that it has to be in normal rate. So we're going to ask, is this fast or slow or just right? And as all nursing students know, we like it to be 60 to 100. You also have to know, is there a P wave? Yes or no? Does the P wave look normal? And is that PR interval less than 0.2 seconds or 5 small boxes or 1 big box? Is the QRS normal in less than 0.12 or less than 3 small boxes? And then we will sometimes hear about the QT interval. Just so you know, that's going to be from around 0.4, about 10 small boxes, give or take a few there. With that, so we need to look at, is it fast or slow? Is it regular or irregular? And when we're saying that, we are counting from the top of that QRS complex or that R wave, and we're kind of marching those out. Do they seem regular, equal distance apart? And then again, do we have P waves? Do they look normal? Do we have a QRS, a normal looking QRS, and a normal T wave? And if all of those things are a yes, then it is normal sinus rhythm. So how can we tell if something is different? And that goes into just knowing your basic conduction system in the heart. So where does that conduction system in the heart start? You will learn that, yes, it kind of starts in that SA node, high up in there in your right atrium. It then goes to the AV node in the lower right atrium, and then it's going to travel down the bundle of His and the bundle branch blocks, or bundle branch branches, and then out to the Purkinje fibers in the ventricles. And if all is working right and working correctly, as you can see, the intrinsic rates, SA node, if everything's working great, it'll be 60 to 100. If our SA node gets taken out by some reason, ischemia, damage, something like that, the AV node is able to kind of take over at 40 to 60. Not great, but hey, not so bad. And then once we get down to the Purkinje fibers, you can see how that really slows the heart rhythm, and it really moves slow. They say the lower you go, the slower it is. So I like to think of normal as being that SA to AV node being, if you want to picture it, so to speak, being a cute little jump from the SA to the AV node. That there is going to be that P wave, that cute little P wave jump there. Then we're going to travel down that QRS complex. To me, if you visualize it, it does kind of look like it would be something that would go down. There's actually 2 little bundle branches there. And start to go around, and that right there, bam, is going to be your QRS complex. I like to think of the T as kind of going back to the start, if you will, a reset, as you will. Okay, and that's going to be your T wave. So when we're evaluating telemetry strips and heart rhythms, if you kind of know these basic processes, you can figure out where the problem really is. So in atrial fibrillation, for example, which is a common heart rhythm we know that it kind of gets a little wonky. And with that, we'll throw one here. So we're looking at the AFib that is a common heart arrhythmia that nursing students are usually going to see. As we can see, there aren't really any pretty little P waves. So we know that this SA to AV node, which usually likes to cause that cute little jump, so to speak, isn't really happening so much. So we know if the P waves don't look right and don't look good, there's something likely happening in the atria, okay? And in AFib, in that case, there's lots of little complexes kind of triggering, and the SAAV node, they're all confused. They can't figure things out. If there's something wrong with the P wave, we know that there's something probably wrong in those upper level of the heart, in that atria, in the intrinsic pacemaker of the SA or AV node. That's some sort of atrial arrhythmia. Makes sense, right? If there isn't that cute little jump, the SA and AV node aren't connecting right. Now let's move on to another one. Now here we have an example of something here that is very similar to what a ventricular tachycardia may look like. So what we know from looking at this is that yes, we're not really seeing any P waves. However, the main issue here seems to be these QRS complexes. The QRS complexes are wide. They don't look normal. So in this case, we recognize that if the QRS is the issue, that bam, it is likely an issue happening in our ventricles. And in this case, same thing. These are just responding crazy. There's a crazy little party here. They're going too fast. And therefore, we know there's a ventricular issue with that. And the last little bit here, you may see on some medications, the side effects may list prolonged QT. Now, a common medication that nursing students may give, maybe some ondansetron, some Zofran, some of those type medications, if you read on some of the side effects or contraindications, it may say prolonged QT. And why should we care about that? If we go back and we think of that prolonged QT, or the T wave, so to speak, being the restart of the heart, if it's taking too long for that heart to restart, if you can envision, you could have something starting from anywhere if the process is going too slow. So what happens here with prolonged QT is you can actually have the heart almost trip itself up, and it may go into a lethal arrhythmia. So prolonged QT, we do need to care about that. So this is why if your patient maybe ordered like that ondansetron or something, you're like, wow, my patient's here for, nausea and vomiting and diarrhea. Like, why am I doing an EKG? The providers are trying to be safe, and they are looking at that prolonged QT to ensure that this is a safe medication to give the patients. With that, so students, just remember, I like to look at that SA to AV node. I like to visualize it as a short little hop. And if it's not there, or if it's abnormal, you likely have a atrial conduction issue or some sort of atrial arrhythmia. If your QRS complex is wide and or just looking goofy, you likely have a ventricular problem. And if we talk about the QT interview, it's the heart's kind of taking too long to figure itself out. This can cause a lot of issues. This little rainbow rhythm here, this is my very crude drawing of a supraventricular tachycardia. Now with this, we can't really see P waves. It looks pretty regular. So, AFib tends to be a little bit more irregular, but this is fast. So again, we can't really tell if there's a P wave issue or something like that. So we may call it supraventricular or some sort of tachycardia, supraventricular tachycardia. It's rapid, and something's happening above the ventricles, supraventricular. And again, we can tell that because we can't really see P waves. So there you have it. Super simplistic. SA to AV node, little jump, bundle of His, and Purkinje fibers. Hope that helps. Good luck, students. Don't worry, you will figure this out. We got this. All right. After you graduate, if you do have to be on a tele floor, they will likely send you through a telemetry class. This does get way more in depth, but hopefully that helps you understand. As I tell my students, even if you don't know exactly what the rhythm is, if you can systematically start to think of, is this fast or slow, regular or irregular? Do I have P waves? Is that PR normal? Is that QRS narrow and normal? Is my T wave looking there? So even if you can't identify what it is, hopefully you can use terminology that may help someone else figure it out. So best of luck. See ya.